Now we will be discussing few important facts related to your obstetric sections also, where I will be discussing few type K questions and more type A questions. Like one liner will be having more, but elaborative discussions on all those important aspects. So our target only is to all EDIC preparators is to go and read that topic thoroughly from either from any of the your critical care textbook, because the questions may be hovering around that topics only, because we used to discuss based on our participants, that what they have given us the feedback after they qualifying their EDIC part 1 previous batches. Okay, and based on that they tell us the area of interest of the every year EDIC questions, because many of the time the various topics are going to get repeated, like pregnancy adaptations. They will be going to ask one or two questions related to pregnancy adaptations. They can ask questions related to your amniotic fluid embolism, then your peripartum cardiomyopathy, then your preeclampsia, then your DIC, then your some questions related to maternal sepsis, where they want to check for cervical sepsis guidelines related to pregnancy as well. Few of the questions related to your like reversible encephalopathy, like pregnancy-induced reversible encephalopathy, press, as well as a few questions related to your I think some recent studies also for related to postpartum hemorrhage as well. So I will not take much time. First of all, I will start with type K questions. Okay. So meanwhile, you can answer same like what we have discussed right now in previous lectures. Now, if the first is here, I have made one question related to your woman trial. Okay, woman trial is World Maternal Antifibrillary Trial. So it is very older trial. Like in 2011, the trial has been there, but there are two studies related to woman trial in 2011, and then in 2018, the another modification of that woman trial was there. So they have so we want to test the knowledge related to your tranexamic acid for the treatment of PPH in women trial. So what this trial talks about. So you have to mark the true and false statement. So this women trial has provided a reliable evidence that tranexamic acid reduces the mortality and hysterectomy in women with clinically diagnosed postpartum hemorrhage. First. Second, the loading dose for tranexamic ranges from 2.5 milligram per kg to 100 milligram per kg, and here maintenance dose from 0.25 milligram per kg body weight per hour to 4 milligram per kg body weight per hour, and the duration need to be 1 to 12 hours. Okay. So, and third point is this tranexamic acid passes into breast milk in very low concentration, approximately 1/100th of the concentration of maternal blood. And tranexamic acid will be compared with matching placebo like DNS 0.9% sodium chloride and dextrose 5%. And this trial is a randomized, double-blind, placebo-controlled trial involving around 13,000 women with clinical diagnosis of postpartum hemorrhage. So these are all options in front of you. You have to mark true and false statement. Okay, very nice. Many of you have started marking these questions. I hope that few more students come and join this interactive discussion. I think that will be great help for me also, and it engage the class in a very well coordinated manner as well. So because you can read those options, many of the questions is going to get directly going to get repeated. I'm not sure, but at least you will try marking answers here will push you to read more and more. Okay, good. So I think three of you have marked this question. So just see that answer. So the first statement, the woman trial has provided a reliable evidence. First is true. The loading dose here about tranexamic acid is not true. And the third option, like it passes into breast milk in very low concentration. Again, this statement is true. And fourth options like tranexamic acid it will be compared with matching placebo, so it has not been there. And women trial is a randomized control trial, double blind trial with involving 13,000 women. I think I will be requesting you to go and read this women trial study protocol. It was published by Shakur in 2010. Here, what they have done, tranexamic acid for the treatment of postpartum hemorrhage, international randomized double-blind control trial, where this trial has been done on 15,000 women with clinical diagnosis of postpartum hemorrhage. Okay. And here, all legally adult women have diagnosed with PPH with vaginal delivery safe were potentially eligible. And here, the antifibrinolytic, particularly with in PPH, the treatment given tranexamic acid dose is 1 gram IV injection, and placebo only sodium chloride was there, will be as soon as possible after randomization. And the second dose is given after 30 minutes if bleeding continue, or if it is stops, again you can restart this tranexamic acid infusion after 24 hours of the first dose. So here, this trial was randomized randomized double-blind placebo-controlled trial. Okay, so here I think the subgroup, they have done a subgroup analysis for primary outcome, which is based on the type of the delivery, whether administration or not prophylactic uterotronics, and then decision to consider trial entry was based primarily on the estimated blood loss and on the maternal hemodynamic stability. So it studied about 15,000 women with or over 90% power to detect a 25% reduction from 4 to 3% as a primary outcome. So simultaneously after that, they in 2018, again, the modification of these women trial was there, in which the effect of early tranexamic acid administration based on the mortality, hysterectomy, and other morbidities in women with PPH were studied. Okay, so again, it was a randomized double-blind placebo-controlled trial in which the objective was to check whether early administration of tranexamic acid reduces the death. So their study, where primary outcome was to study the death from the bleeding in women with PPH, and they have done it in 20,000 patients, and all those patients were having more than 16 years, and primary outcome was death from all causes, and they compared with his placebo, and 10,000 patients were receive a tranexamic acid, and the second was hysterectomy within 42 days. So this was the primary outcome, and the secondary outcome was death due to bleeding, death due to other causes, and finally the adverse event they have mentioned. And then they concluded that tranexamic acid reduces the death due to bleeding in women with PPH with no additional adverse effects, and when used with as a treatment for postpartum hemorrhage, tranexamic acid should be given as soon as possible after the bleeding onset. So this is all about, in nutshell, about the woman trial. So go and read this woman trial also. You can have too many ideas about, because one options that what is here that I haven't discussed about this point, this transaction is passed due to breast milk. This is a true statement. You can, while reading this trial, you will have that answer. Okay. Now coming to the next statement, now again this is a very important question that I have framed this question related to severe preeclampsia and suspected HELP syndrome for receiving parenteral magnesium sulfate therapy for as a prophylaxis of convulsion. So here the magnesium regimen is being tested, whether the magnesium sulfate regimen include a loading dose of 6 gram over 20 minutes, or you can start with a continuous infusion of 2 gram per hour starting during a period of observation, and you have to continue 48 means 2 days postpartum. And if in between the recurrent seizure is there, you can give an additional 2 gram of magnesium sulfate over 3 to 5 minutes. The D option is, if seizure is not controlled, even after 3 boluses of magnesium sulfate, you can add anti-seizure drugs like Dazi or Lorazepam or Midazolam. And ECOG task force recommend that antihypertensive therapy for severe preeclampsia and HELP syndrome is only if your blood pressure is going above 160 by 110. Okay, so you have to write true and false statement. So okay, okay, all first 2 options are false, and then rest 3 statements are true. Good. So at least you all guys are marking. It's nice. Now you see that answer. So if we'll see, the first option is true. So magnesium sulfate regimen is 6 gram IV over 20 minutes. Second option is not true. It is false, because continuous infusion of 2 gram per hour is the correct dose, but the duration is not right. And the third option is true. If your patient is having a recurrent seizure, definitely you have to add 2 gram of magnesium sulfate as an additional bolus doses. This option, D option, is again not false. Again false. Why? Because if seizure is not controlled by 3 bolus doses of sulfate, you can try anti-diazepam lorazine. No, it is not right. But ACOG task force tell that preeclampsia, if the patient will have a preeclampsia along with HELP, the target cutoff value for treatment of hypertension would be 160/110. So this is correct option. Now you see this good. I think this has been taken from a journal like Obstetric Gynecology, NEGM, and Obstetric Gynecology as well. The first is, if the patient is having a HELP syndrome, parent with preeclampsia, severe preeclampsia with HELP syndrome, you will start with a magnesium sulfate of 6 gram over 20 minutes, followed by continuous infusion of 2 gram per hour, starting during the period of observation and continuing not 48 hours postpartum, 28 hours for 24 hours postpartum. And if the patient have a recurrent seizure, you can give additional doses of 2 gram over 3 to 5 minutes. And third, if the seizure is not controlled after, not 3 doses, only after 2 doses of magnesium sulfate, you have to add anti-seizure drug like diazi, lorazine, and midazolam. And ACOG task force recommended that antihypertensive therapy help with preeclampsia. The cutoff values 160 by 110 millimeter of mercury. Okay. Coming to the next question. So again, this question is related to platelet transfusion and HELP syndrome. Okay. So we'll read here the various types of HELP syndrome. So what is the class of HELP syndrome? The platelet transfusion is suggested for patient with class 1 HELP syndrome before C-section. Platelet transfusion is suggested for patient with less than 25,000 per microliter before vaginal delivery, and actively bleeding patient with thrombocytopenia, and all those patients with platelet count less than 20 should receive a platelet transfusion to prevent excessive bleeding during delivery. If you want to add a platelet transfusion to corticosteroid therapy, if you want to add, it improves the platelet count and it improves the maternal count in HELP syndrome, which is true or false. And repeated platelet transfusion required due to your short half-life of platelet. Okay. So I think Venkat, can you please mute your mic? Venkat, please mute your mic. Thank you. So now, what do you feel that which option is right and which option is wrong? Okay. Very good. So many of you feels that first option is right, the second option is false, and rest 3 options are true. Good. It's good that you all guys are attempting. Now you see that why these options are there. So first option, definitely, if you look for the Mississippi classification for HELP syndrome classification based on your severity, the class 1 is very, very severe. Go and read that Mississippi classification. There are 3 class 1, 2, and 3. The class 1 is very severe, class 2 is lesser severe, and class 3 is mild. So for class 1 HELP syndrome, the platelet transfusion is suggested. Definitely it is right. The platelet transfusion is suggested with patient less than 25,000 before vaginal delivery. No, for vaginal delivery, the cutoff is not 25,000. If the patient is actively bleeding with thrombocytopenia and with a platelet count is 20,000, these must receive platelet transfusion to receive excessive bleeding during delivery. Yes, this is again the right option. And then the D option, like if you want to add corticosteroid to the platelet transfusion, it will not improve or increase the platelet count, and neither it will improve the maternal outcome. So it is not again a true statement. And if you want a repeated platelet transfusion are required because they have a short shelf life of the platelet. No, again, this is not true. Now you see why. So the platelet transfusion is suggested for the class 1 syndrome with severe thrombocytopenia. That's why it is severe thrombocytopenia. So the cutoff is less than 50,000 before CS. And when the platelet is 20 to 25,000 before vaginal delivery. So before vaginal delivery, that counts between less than 20,000, but not below 20,000. It should be between 25 and 20,000. And if the patient is actively bleeding, platelets with thrombocytopenia, all those with platelet count less than 20,000 platelet should receive a platelet transfusion to prevent excessive bleeding during delivery. And Vigil de Gracia reports, they have suggested that if you'll add corticosteroid therapy to platelet transfusion to increase the platelet count. It does not improve the maternal outcomes in HELP syndrome. Okay. So this is, and third option is here, repeated platelet transfusion are not required due to short half-life of platelets. So I hope all those options are clear. Now coming to the next statement regarding amniotic fluid. So I have kept two questions for amniotic fluid embolism. Here the first question is true and false type, and one question is your type A type. So there are two types of amniotic fluid embolism: typical AFE, which is also known as classic, and atypical AFE. So typical AFE has three phases. Phase 1, respiratory and circulatory disorder. Phase 2, coagulation disturbance and maternal hemostasis, like coagulation disturbances. Phase 3 is with ARF and ARDS, leading to cardiopulmonary collapse. Atypical have cardiopulmonary collapse, but not due to first symptoms in life-threatening hemorrhage due to DIC. And many of these patients has hypoxia or hypoxemia, progress to circumoral and peripheral cyanosis. And here AFP may occur up to 72 hours post-delivery. AFP may occur in healthy women during labor, during CS, or during abortion and during second trimester pregnancy. So just write a mark which you feel that is true. Keep fast, keep attentive. All true. Okay. Any more? Anyone? Okay. Anand also feel that all those options are true except last. DNF. Okay. D is false. Good. So I think it's a very interesting question. Okay. See the answer. This is true. This is true. This is true. This is not true. This is not true. And this is again true statement. So till now, you'll get all information related to your amniotic fluid embolism. Now you see why. So there is, I think this has been taken from a review article from JOCP in the year 2016. I feel very interesting. The article is very interesting, and it has a good discussion related to your amniotic fluid embolism, where it is the first part is your classic. The first part is your classic. Here the three phases I have already discussed. The second part is atypical, where here the cardiopulmonary collapse does not occur in atypical embolism, but the first symptom is life-threatening. Here the DIC is the most common presenting features in atypical AFE, but in typical or classic AFE, the patient will have a cardiopulmonary collapse. So this is the important differentiating findings between typical and atypical AFE. Now the second is important. These patients have a clinical presentation which has been written here, and then after that this patient will have a 4 criteria like acute hypotension, acute hypoxia, and coagulopathy. Okay, and this is, I think, if you post delivery you want to see. So here I think somewhere written. So these patients have also tonic-clonic seizures that's seen in 10 to 15% of the patients also, and many of the patients have coagulopathy or severe hemorrhage. So again, this article is very interesting. You all guys can go and read this article. So it is JOCP and Journal of Anesthesiology and Clinical Pharmacology. You can just type JOCP and June 2016 session. So it is written there. Okay. Volume issue is 2. So it 2016 article, AFE, Journal of Anesthesiology and Clinical Pharmacology. Okay. Now coming to the type A question. So one-liner, now again we'll discuss about one-liner. The first question is about PPCM. So peripartum cardiomyopathy. All of the following statement are true except. So it is development of heart failure in the last month of pregnancy or within 5 months postpartum. Okay. And the second part is prognosis dependent on the normalization of the left ventricular function. In diastolic, dimension of left ventricle is more than 2.6 and M mode fractional shortening is seen in less than 30%, and board regimen is used for acute PPCM. Okay. So only one answer. Okay, so the answer is C here. The in-diastolic dimension of more than 2.6 centimeter per centimeter square is wrong. Most of the time, the heart failure appears or PPCM develops in the last month of pregnancy or 5 months postpartum. So many of these patients have, within 5 months postpartum, the patient will have a PPCM symptoms. And here the always, if the normalization of the left ventricular function is happening very early, the patient will have a good prognosis. And then in diastolic dimension, this cutoff is wrong. And M mode echo, on M mode, if fractional shortening is less than 30%, the patient is having a diagnosis of PPCM. And board regimen is used for the treatment for PPCM. This board basically stand for your bromocriptine, your OCP, then your aspirin, like that. So then you have to decrease that ritodrine, and then your diuretics. So this is all about treatment for acute PPCM. You can read that board regimen later on also. So now here the diagnosis for PPCM is at the end of the first month, or at the end of the pregnancy, or of the first month postpartum. So last month of the pregnancy, or first 5 months of the postpartum. No history of previous cardiac dysfunction. New left ventricular systolic dysfunction. EF is less than 45%. M mode shortening of 30% with more than 2.7 centimeter square of in diastolic dimension. So your EDD, or in diastolic dimension, would be at least 2.7. So it should be more than equal to 2.7 EDD, centimeter per meter square. Okay. And this is the diagnostic criteria. I have already discussed all those diagnostic criteria. Now coming to the next question, a 33 weeks pregnant patient is there. She is having a preeclampsia and brought to the emergency room with isolated head injury. Okay, the head injury was only isolated head injury, and because of the blow over the left temporal bone. On examination, the GCS was 6, and she has a fixed and dilated left pupil. Okay, the blood pressure is 170 to 115 millimeter, and she has no signs of extracranial injury. The cardiotocography shows no abnormality, and plan to intubate and ventilate. The plans are made to intubate and ventilate the patient to facilitate an urgent CT brain. Now, which of the following statement is true? Which statement is true, you feel? I think answer is already given. So here, the preeclampsia is a predictor of difficult laryngoscopy. The baby must be delivered by C-section prior to CT scan. No, this is not right. Opiates should be avoided. Definitely opiates should be avoided because it will pronounce more fetal distress. Nitroprusside is the first line agent for blood pressure control. Again, it is not right. And then intravenous lignocaine should be given to attenuate the pressure response. No, in these situations, no. Now coming to the first, intubation of preeclamptic patient is always fraught with danger, right? First option. So it is the correct answer. Potentially, if the patient is have a difficult, if the potentially difficult airway pregnancy is always, these patients have difficult airway with facial and tongue edema, so their direct laryngoscopy is difficult. The pressure response to intubation can further rise in the blood pressure, rising the stroke, or may expand the intracranial hemorrhage in this case. This response can be attenuated with not using long-acting opioids, but short-acting opioids like alfentanil. Intravenous lignocaine may be effective in this regard, but it can cross the placenta and may accumulate in the fetal brain, causing acidic fetal environment or iron trapping due to ionization of the basic drug. Now, this is a very important molecular mechanism or mechanism of action of all those local anesthetic, amide-based local anesthetics, which can cause or which can lead to increase in the acidic fetal environment because of the iron trapping or ionization of the basic drug. Second, nitroprusside is very effective in lowering the blood pressure, but it can directly reduce or it can impair the cerebral perfusion pressure. So it has so much of undesirable side effect like lactic acidosis and cyanide toxicity as well. And that's why it is reserved for the hypertension if it is not settled with other organ agents like labetalol. The fetus is not compromised, and while early delivery may be advised, history suggestive of extradural hematoma is given. In this case, if we'll do early CT brain scan and evacuation, hematoma will be a life-saving, and always multidisciplinary team approach. Okay. Now here, a 36-year-old woman, she is receiving magnesium sulfate for severe preeclampsia. We have just discussed the role of magnesium sulfate with severe preeclampsia at 35 weeks of gestation. Now, each of the following maternal effect of this treatment except sedation, hypocalcemia, sensitization to non-depolarizing muscle relaxant, cardiac dysfunction prior to respiratory depression, and loss of DTS prior to significant cardiac dysfunction. Okay. So we have got a very quick answer. But here the option is this one is not right. Cardiac dysfunction prior to respiratory depression. Now you see why. Now this magnesium sulfate, if you are going to administer with a predictable maternal effect, so loss of DTR happens at 4 to 6 milliequivalent. So at least 4 to 6 milliequivalent per liter of magnesium value, which is followed by somnolence and respiratory depression. So at 8 milliequivalent, the respiratory depression will be there, and at 50 milliequivalent, the cardiotoxicity will be there. And magnesium sulfate also cause flushing and like because of vasodilatory effects and hypocalcemia as well. And these magnesium sulfate also sensitize the patient to NDMR, like non-depolarizing muscle relaxant. And that's why always lesser extent of depolarizing muscle relaxant are required. So small doses are required because they are very, very sensitive to NDMRs, like non-depolarizing, like vicuronium, your atracurium, rocuronium. So these agents are half doses or a smaller doses, 1/4 doses are required if the patient is receiving magnesium sulfate. Okay. So now brain MRI, if you want to do a brain MRI in eclampsia, typically what it will show? It will show a normal brain. It will show a periventricular white matter T2 fluid attenuated inversion, like it will show a flare response. It will show a T2 flare lesions in multifocal parieto-occipital subcortical regions. It will show pontine lesion. It will show cortical infractions. Okay. So you think that many of them thinks that it caused periventricular white matter T2 flare, and few thinks that it is a parieto-occipital subcortical T2 flare. So T2 flare will be there, but at which location? This is very important, whether periventricular or parieto-occipital. Okay. So again, this is a very important question. So I think the answer is typically it is a parieto-occipital subcortical. So this you must remember that in eclampsia, the parieto-occipital multifocal T2 flare lesion will be there. Now you see why. Now here the multifocal parieto-occipital subarticular flare are seen in almost patients with preeclampsia if MRI is obtained soon after convulsion. So if you are obtaining the MRI soon after convulsion, this is mostly seen. Multifocal parieto-occipital subcortical flare lesions, and it can be also seen in preeclampsia, but the pattern is almost identical to what is seen in PRESS. So in PRESS also, posterior reversible encephalopathy syndrome, this pattern is usually seen. So you can see this parieto-occipital subcortical flare lesion could be seen. Okay. So this is bilateral parieto or multifocal, because this is related to multifocal parietal subarticle flare lesion. So it could be seen in preeclampsia if you obtain just after the convulsion, or many of the patient, it is identical to PRESS. So you must see the history very closely to rule it out from PRESS. If the patient will, if the option will be given like preeclampsia, eclampsia, or PRESS, then you have to look for the clinical findings for the PRESS to make it out, mark it correctly, because many of the time you might be getting these kinds of MRI scans. Now coming to the next question, a 36-year-old gravided to para 1, 35 weeks, 3 days, present with nausea, vomiting, muscle ache, and then sudden onset of severe right upper quadrant pain for 2 hours ago, and then presented to a doctor. Now urine dipstick shows no proteinuria, but she has a headache, and the most common maternal complication of this syndrome is, what will the common cause of severe right upper quadrant pain within 2 hours? It's associated with the headache, but no proteinuria. Anyone? It could be seizure, DIC, liver rupture, cerebral hemorrhage, or pulmonary edema. So it is DIC. Now this is a very tricky question again. Why? You see that this case, because this case vignette is describing the patient with hemolysis, elevated liver enzyme, low platelet syndrome, which is defined as a hemolysis with MAHA, like microangiopathic hemolytic anemia features, usually appears in the third trimester, although it can occur earlier or postpartum. It is associated with severe preeclampsia and eclampsia. Okay, it is associated with severe preeclampsia, and here the maternal complications include DIC most frequently. Also, second DD would be liver rupture and cerebral hemorrhage and pulmonary edema, right? So fatal pontine hemorrhage and cerebral infarctions have been described, but it is not much common like DIC. And neonatal complications like your IUGR or placental abruption. If the syndrome develops after 34 weeks, the delivery is usually recommended. Good. So here, most of the options here, right upper quadrant pain, the patient will have a sudden onset of right upper quadrant pain, and then presented to doctor, urine stick, no proteinuria is showing, severe patient will have a headache. So here they are talking about the DIC that may has happened due to severe preeclampsia. Okay. So eclampsia and severe preeclampsia, that you have to know that if the convulsion will be there, the patient will have present with eclampsia, and the patient will maybe or may not be, the proteinuria may not be positive many of the times, but the patient will have an increased blood pressure, will show a signs of HELP as well. And I have already discussed the one question in which HELP has been combined with severe preeclampsia leading to that DIC, where the role of platelet transfusion along with corticosteroids, the role for vaginal delivery cutoff, the role for platelet count for cesarean sections, all we have discussed. Okay. So this is continuing to that question. Now, again, the next question is, the patient is now here 2 days postpartum, right? 2 days postpartum, sudden onset of worst headache of her life, BP on arrival 180/90, somnolent, no non-focal deficit on examination, and opening CSF pressure was normal, and CSF was clear, normal chemistry, normal cell count, and image shown where the fall. I will show you the following image later on, but till now, before that image, you can mark this question, because when I will go to the next image, I think answer will be seen. Okay, so I think many of you are marking press. Okay, how many of you are with RCVS, reversible cerebral vasoconstriction syndrome? Still press. Okay, so this is the picture. This is the angiography picture, and this is the CT scan. So here the option is D. Now I will tell you why the option is D. Why the option is RCVS, not press. Now see. Now these RCVS, that is your reversible cerebro reversible cerebrovascular constriction syndrome, vasoconstriction syndrome, is a group of disorder. These groups have already a similar clinical and radiographic characteristics. So it mimics with Call Fleming syndrome, it mimics with benign angiopathy of the CNS, migrainous angiitis, drug-induced cerebral angiopathy like regular uptake of SSRI or marijuana, and some postpartum angiopathy as well, in which it is leading to because of the hormonal changes. So these patients always present with thunderclap headache, with or without focal neurological signs, with normal CRF analysis, without any evidence of CNS inflammation, and exclusion of all other sudden severe cases like aneurysm, like SH, presence of segmental cerebral arterial vasoconstriction on catheter, and CT scan and MRI shows resolve within 12 weeks. Many of these patients, within 3 months, the patient will not have any findings on cerebral arterial vasoconstriction. And cortical subarachnoid hemorrhage is the most common radiographic finding, which is non-aneurysmal. So here I think this is a arterial vasoconstriction which you can see on catheter or angiography, arterial angiography. Okay. Now coming to the next point. So what is the gold standard for diagnosing these patients or detecting? So mostly you want to see the segmental vasoconstriction on conventional angiography. So this is the picture showing conventional angiography, in which you may be seeing that cerebral vasoconstriction, which is responsible for lesser feeling here. Many of the areas are not good filled because of that significant cerebral vasoconstriction. That's why the flow is not adequate. If you compare this flow and if you compare this flow, the adequacy of the flow is not there because of the cerebral vasoconstriction. Now, coming to the next part is, in most of these patients, they may resolve without any treatment, or you can add calcium channel blockers like limodipine or verapamil. Glucocorticoids or IV magnesium can be added. These are always benign, and severe vasospasm may be reported, leading to transient attack like TIA, seizures, and ischemic hemorrhagic infarctions as well. Many of the times, intra-arterial milrinone and verapamil has a role, as well as you can do a cerebral angioplasty. In these cases have been attempted to some success in severe or refractory cases. So if asked, severe RCVS or refractory RCVS case, intraarterial milrinone, verapamil, as well as angioplasty may be the right choice for treatment. And why not preeclampsia? Because preeclampsia is defined as a pregnancy-induced hypertension with proteinuria, and there is no information about urine studies is given in this case. That's why. And even in this case, the condition is not associated with any imaging finding in cerebral vasoconstriction. Why not preeclampsia? It is a life-threatening condition occurring in pregnancy, and here the tonic-clonic seizures in the setting of preeclampsia, the patient will have a goal of 4 to 7 milliequivalent of magnesium. If the patient will have continued to seizure, the dose of magnesium may be increased. So if 2 dose of magnesium is refractory, then you have to opt diazepam or lorazepam, that what we have discussed later on. Earlier, we have already discussed. So IV anticonvulsant and mechanical ventilation can be initiated in refractory cases. Why not press? Because it is characterized by headache, confusion, seizure, and visual loss. And although if you'll see classically that what we have discussed earlier on MRI, it is going to get involved the parieto-occipital lobe, means T2 flare will be seen on brainstem, cerebellum, and as well as cerebellum. And many of the time, it may extend up to temporal or frontal lobes. And press maybe occurs in the setting of malignant hypertension or using tacrolimus or cyclosporine. Why not Shinhan syndrome? Because this postpartum pituitary necrosis, these occurs usually is a complication of panhypopituitarism. And this patient will present with agalacturia, right? Now coming to the next question here. Now here, 23-year-old male, postpartum, day 2, normal vaginal delivery, receive epidural anesthetic, which was wet tap with spinal leak. The patient is ready to discharge home, but she was complaining of lingering headache and mild nausea. And now it is attributed to spinal headache. Which has been attributed to a spinal headache. Now she then has a generalized seizure and become not arousable, so difficult to arouse. Sclera was also red, and she is intubated, taken for NCCT, which shows diffuse cerebral edema first, multiple vessel dilated in the vertex, and there are 2 small cortical hemorrhages, 1 centimeter in the left frontal lesion and other 6 millimeter in the right parietal lesion. So what could be the probable diagnosis in this case? So very typical finding. Okay. Anyone more? I think if you verge with that CT findings, I think the straight away diagnosis is there. Good. Many of you have marked it right. So this is your classical case of cerebral venous thrombosis. So this is cerebral venous thrombosis. Now you read why. Why this is so? Because you will see a dilated cortical veins and then empty delta sign. So this is empty delta sign, which with contrast on using contrast on doing CT scan, the dense sinus sign become empty delta sign, and it is present in 33% of the cases. However, many of the patients have normal CT scan, and this patient difficult because NCCT have high degree of suspicion. And if you will do as contrast CECT, it will reveal the thrombosis more readily. And if suspected, you can go with a contrast enhanced CT scan for checking the dilated cortical veins, cortical subarachnoid blood as well, and then dense appearing your cerebral sinuses as well. So many of these patients, what happens that number of the patients who lack these vascular risk factors, like many of these patients have venous thrombosis, like pregnant women have venous thrombosis risk, like having a hematological, some patient are oncological or autoimmune disease, they can present, head trauma patient can present with venous thrombosis as well. The finding is scleral injection and venous insufficiency is very likely. Ruptured AVM and aneurysm may be expected to produce more obvious signs of subarachnoid hemorrhage in patient who deteriorates rapidly, and brainstem infractions should not produce cortical hemorrhage. So these all are options that why these are not true. Okay. Now coming to the 8th question, a 36-week pregnant patient now admitted to hospital with nausea. She is hypertensive, BP 160/100, no headache, no visual disturbances or hyperflexia. Blood test abnormalities include bilirubin, slightly raised, ALT, so transaminitis, and your prothrombin time is also increased with pivnogen. Plasma glucose is only 38. My likely diagnosis is. So what do you feel that which is right? Okay, good. So many of you are going with acute fatty liver of pregnancy. So I think it is right. So this patient with is having an acute fatty liver of pregnancy, which has a very high mortality, and this patient always present in third trimester. So by this hint, you can think of that this patient is having acute fatty liver of pregnancy with microvascular fatty infiltration, fatty acid oxidation defect with no significant inflammation or necrosis of the liver, and these always coexist with preeclampsia where the patient will have elevated transaminase and deranged coagulation. Hypoglycemia is also common in these groups of patients, and hepatic incaf may supervene in severe cases. So it is a straight away of AFLP. Now, why there is a significant overlap between HELP and but marked elevation of bilirubin, hypo, and severe clotting derangement in AFLP as per your Swenson criteria confirms that patient is having a acute fatty liver of pregnancy. If you will see a marked elevation with a good rise in serum ammonia as well, severe clotting factors rearrangements, and if the patient will have a right upper quadrant pain, if hemodynamic is stable, if hemodynamic stability is there, you can think of liver hematoma. Cholestasis of pregnancy cannot cause a very high rise in bilirubin, and viral hepatitis is always associated with higher level of transaminitis, maybe in a tune of 500 to 1000, not up to 1000, not up to 100. Now, coming to the next question, a 33-year-old woman, right upper quadrant pain, generalized abdominal swelling. She is previously well, no medication other than OCP, past medical history unremarkable, and she is having only a DVT history. Hepatomegaly, ascites, and peripheral edema are present on clinical examination. Ascitic fluid analysis showing a neutrophil count of 10 per millimeter cube, and SAG ratio is 1.3. So your SAG is 1.3 and 24-hour urine concentration is 90, and she has no any alcohol intake history, so most likely diagnosis. Again, now this is again a straight diagnosis. Okay, anyone more? Good. So I think you all guys are marking it right. So it is Budd-Chiari syndrome. So here the answer is Budd-Chiari syndrome, because here you have to pick it from the SAG ratio as well as your protein concentration. Now your Budd-Chiari syndrome, why it happens? Because of the obstruction to the hepatic venous outflow, and it may occurs because of the taking oral contraceptive pill. So here one option is here this is the another first hint. The patient was on OCP, so the chances for getting that Budd-Chiari is very high. The patient is again the pregnant also, and the patient is having a triad of acutely presenting symptoms like ascites, hepatomegaly, and abdominal pain. And here in the latter case, the collateral circulation has time to develop and ascites may be minimal. And Doppler USG ultrasonography is a reasonable, sensitive, and specific screening investigation. Okay, although hepatic venography is the gold standard. Now, management is diuretics and sodium restriction. You can add anticoagulation, and then here the SAG ratio between portal hypertension ascites more than 1.1, and it was considered more accurate. Okay. Nephrotic syndrome, here the protein excretion is more than 3 gram per day, and SBP, the neutrophil count is more than 250 millimeter cube. Now coming to the next question, 41-year-old female, abdominal pain, nausea, vomiting, diarrhea, examination showed mild jaundice, atrial fibrillation agitated, bibasal crackles, on chest calculation, blood pressure is 76/40, heart rate is 134, and SpO2 is 93. She is mildly deranged liver function test, normal WBC, C-reactive protein, and beta HCG suggests she is pregnant. And what is the more likely diagnosis? Beta HCG. So you are going with ectopic. Why? Decompensated alcoholic liver disease. Okay. Anyone more? Beta HCG. Ectopic. Anyone? Thyroid storm. Good. I think you marked it right. So the answer is thyroid storm. Now see why. So here the combination of symptoms is this patient is having a constellation of symptoms. Okay, that's why the changes for the choice for thyroid storm is more, because pyrexia is not generally a feature of decompensated alcoholic liver disease. So first your option is very much ruled out, that here the patient is having a Pyroxia, like temperature is 39.6. So many of the very frequently it is associated with decompensated alcoholic liver disease. And sepsis is unlikely given the normal white cell count and inflammatory markers. So you rule out sepsis also. Now coming to the patient with malaria, they usually present with fever, headache, malaise, and GI and jaundice and respiratory symptoms can be seen. However, malaria doesn't have tachyarrhythmia and cardiac failure. So again, the malaria is also ruled out. Now coming to the thyroid storm. So now these thyroid storm represent an extreme in the spectrum of thyrotoxicosis where decompensation of many organ functions can occur. So what happens here, the transition into a state of thyroid storm is usually required a second superimposed insult. So second hit, you will get, so what will be the hit? Maybe because of the infection, maybe because of the trauma, surgery, myocardial infarction, diabetic ketoacidosis, pregnancy. So pregnancy or parturition can precipitate these transition of state into thyroid storm, and any classical signs and symptoms of thyrotoxic state may be seen. So pyroxia is almost universal, 39 degrees Celsius, when present in unwell patient. Even the patient is well, even the patient is unwell or known thyrotoxic should prompt immediate consideration of thyroid storm. And here the cardiac decompensation may be there, which is mostly high output cardiac failure, tachyarrhythmia, usually atrial aneurysm, maybe agitation, delirium because of the neurological involvement or liver dysfunction. So this is all about that question. So thyroid storm will be the correct answer. Now coming to the next question, 28-year-old female, 30 weeks, second pregnancy, feeling unwell, backache, fever, rigors, temperature 39.5, urine analysis, leukocytes plus, protein plus, blood pressure 80/50, heart rate 110, and ECG shows sinus tachycardia. What action most appropriate? You want to admit, you want to arrange ultrasound, you want to give oral antibiotic, urgent CS, send urine sample for microbiological assessment. What do you want to do here? Okay, many of you are going with A. You want to admit to critical care, administer broad spectrum antibiotics immediately. Okay. I think many of you have marked it right. So the answer is right. So answer is A. Why? Because this is the signs of maternal sepsis. So sepsis in pregnant women, they may be less distinctive many of the times than in non-pregnant population, and they are not necessarily present in all cases. Therefore, always a high index of suspicion in these cases. And all healthcare professionals should be aware of the signs and symptoms of maternal sepsis and critically ill. That's why rapid potential lethal course, because these patients deteriorates very rapidly, leading to severe sepsis or refractory septic shock. So classical signs of sepsis need to be remembered, like pyrexia, like tachypnea, tachycardia, hypoxia, hypotension, and renal failure, a loss of consciousness or impaired consciousness. That's it. So here, how will you know, how will you approach these patients? By looking for the signs of pyrexia. This is may not always be present and are not necessarily related to the severity of sepsis as well. That's why the Meo's chart or modified early obstetric warning score may be used for these patients apart from your regular observation of all important vitals. And these are used for all maternity inpatient to identify seriously ill pregnant women and refer to the critical care. Even the early goal-directed therapy has shown to improve the survival for non-pregnant patient presenting with septic shock. SSG have recommended that they must be started earlier broad-spectrum antibiotics while she is to transfer to the NICU. Now the next question, 40-year-old, 41-week pregnant, 6 centimeter dilated, spontaneous onset of labor. She has 2 previous live birth by normal vaginal delivery. She starts compelling headache, chest pain, and rapidly hypertensive, tachypneic, tachycardic. Cardiotocography shows fetal distress. Her oxygen drops to 83. And then on next 30 minutes, she noted to be oozing from her drip sites, GCS3. She brief has a tonic-clonic seizures. Blood shows a hemoglobin 9.5 grams. Platelet is 84. Falling platelets, APD is 54. Prothrombin 23. Fibrinogen is 1.1. ABG is 7.3, 64 kPa, 6.4, PCO2 is 4, bicarbonate is 14. No abnormalities, and ECG shows a left ventricular strain pattern. I think it's a straight. We have already discussed these questions. Good. So I think you're going with amniotic fluid embolism, and we have already discussed about amniotic fluid embolism, the classical type in which 3 phases are there, the phase 1, 2, and 3, in which the patient will have the cardiopulmonary collapse, or it is not atypical type in which DIC happens many of the time. So in type 2 or atypical type, the DIC happens, but in typical type, the patient will have a cardiovascular collapse. But you think that the patient will have no findings on the chest X-ray, and the patient may be showing a right ventricular strain pattern. Now you see why. So you all are right. The answer is C. Now you see why. These amniotic fluid embolism, they present with sudden, profound, and unexpected maternal collapse. And hypotension, hypoxemia, and disseminated here DIC. Here, what has happened, because they have not asked atypical and typical AFE. Okay, so they have combined both the things. That's why they have added DIC also as a part. And in most of the cases, it occurs during the labor and 19% during the cesarean section. Advanced maternal age and multiparity are high risk factors, and these patients will present with pulmonary edema, cyanosis, coagulopathy, and full blood count or coagulation may demonstrate anemia and abnormal coagulation. ABG may show hypoxemia, and X-ray not always show abnormality. Here, I would like to highlight few important findings related to AFE. That first is your ECG. They demonstrate right ventricular strain pattern, and the diagnostic tool include the central venous blood and BAL sample, and then CIL-TN antigen test. So few words about CIL-TN antigen test. So this is CIL-TN antigen test is basically a non-invasive, sensitive method for diagnosing amniotic fluid embolism. But this test, what it do, it detect the release of meconium or amniotic fluid derived from mucin into the maternal circulation. So what is this all about? This is an antigen, and it is a cancer associated glycan that is expressed on multiple proteins, particularly mucins. So many of the time you may get one of the choice like CIL-TN antigen test. So it is used for diagnosing amniotic fluid embolism. So till now, I think that's fine. So again, next question is a previously fit pregnant woman. Now she became mildly unwell in the 3rd trimester, admitted for routine investigation. On examination, she has pulmonary edema. Okay, so pulmonary edema has been noticed, and several spider nevi has been noted. Liver function include the alkaline phosphatase is 100 and albumin is 35, 3.5 gram per dl. And then your alanine is transaminase is 35, and which of the following is correct? So quickly mark this statement. I think again this is a very simple question. This question is with physiological adaptation to pregnancy. First option, second, third, and fourth. Which you feel that option is true? Okay, here the patient is having a albumin is normally low in pregnancies compared to non-pregnant values. So here the answer would be C. Now you see why. So here what happens, this patient pregnancy has a finding consistent with normal pregnancy. Here what happens, alkaline phosphatase rises in normal pregnancy. First point, mild elevation in above the non-pregnant state, but should not be interpreted as evidence of cholestasis. Second, albumin falls. Why these albumin falls? Due to dilation of increased plasma volume, which we all know. Here the total bilirubin is also lowered because albumin is main carrier protein. So if albumin is falling, so total bilirubin will be also low. These patients also shows the signs for stigmata of chronic liver disease in the form of pulmonary edema and spider nevi, which is also common in pregnancy. Now, aminotransferase should be within normal or normal non-pregnant state. That's why the option is albumin is normally low in pregnancy compared to with non-pregnant values. So coming to the 14th number. So a 24-year-old male, female patients, gravida 2, para 2, just deliver vaginally an infant weighing 4.3 gram after a spontaneous uncomplicated labor. Her prior obstetric history shows low uterine segment, transverse cesarean, and for breech. She has no problems during pregnancy. Placenta diverges spontaneously, and there is immediate brisk vaginal bleeding greater than 500 ml. Although all following can be caused for the PPH, which is the now carefully look which is the most frequent cause of immediate hemorrhage in this patient. Immediate hemorrhage, most common cause. Coagulopathy cannot be an immediate hemorrhage, na? Retained placental fragments, again, not. PPH cause, yes. Now you all guys are marking it right. So this is your uterine atony. So uterine atony is the most common cause here for this patient for postpartum hemorrhage. Now you see why. Uterine atony is the most frequent cause of immediate hemorrhage in this patient. Uterine atony refers to the inability of uterus to contract effectively after childbirth, leading to excessive bleeding. Because here uterus is not contracting adequately. Given the patient history of previous cesarean section, the risk of uterine atony is increased. It is important to note that while all other options can cause the PPH, uterine atony is the most common cause in this scenario. Okay. Now coming to the next question. The postpartum nurse calls about a patient who had an uncomplicated vaginal delivery 12 hours ago. Now she is concerned that the patient has following findings. Which of the following findings will concern you most? What do you feel that which finding is most concerning for you all guys considering this patient? Very good. Few of them you mark it right. D is not the option. No. So I think abdominal rigidity, I will go with the abdominal rigidity as well. I will be having a much concern in this abdominal rigidity. Why? Because if the patient is having a vaginal delivery, abdominal rigidity after vaginal delivery could be a serious indicative of serious conditions like uterine rupture or internal bleeding, and that's why immediate attention is required in as these patients to root out further complications. Other findings like leukocytosis, like proteinuria, like pulse rate and single temperature are relatively common and may not be concerning as abdominal rigidity in this context. Okay. So coming to the last question of our day, a patient who is 12 hours postpartum develops a temperature of 104, a tender uterus, increased lochia without an order. Pregnancy course has been complicated by only a limited and inconsistent prenatal care. Your antibiotic choice need to be sure to cover which of the following organism. So again, a very straightforward question. Most commonly seen in these patients where you want to cover which bacteria here. Okay, why you all guys are going with E. coli? No, it's not right. E. coli, you won't cover E. coli here, na, because many of the times with the patient who is 12-hour postpartum, now he has one episode of fever with tender uterus. So I can think of covering this patient with your beta streptococcus infections rather than, because I will think of GBS in these groups of patients. Why? Because this patient has already a high fever, tender uterus, and increased lochia without any order suggests that some infection has already been started in the postpartum period and likely causes your beta streptococcus, also known as group B streptococci. That's why this is common cause of postpartum infections, and it is usually limited with inconsistent perinatal care. Even these are going to get limited, and therefore antibiotic of choice need to cover these beta streptococcus is effectively to treat the infections. So now this is all about from my side, and I hope that today the session is very, very interactive. You do give your suggestions to Forge Academy for so that we can improve it in a better way, or if you want to add, if you want to know something else. So right now, before ending, we have covered women's trial, HELP syndrome, amniotic fluid embolism, peripartum cardiomyopathy, preeclampsia, DIC, a few words about PRESS, few words about RCVS, and then CST or CVT, cerebral sinus thrombosis, AFLP, Budd-Chiari, thyroid storm, maternal sepsis, and few questions related to your physiological adaptations as well. So these are the bunch of topics that what we have covered today as a part of your obstetrics care also. So if you have any query, you can definitely come back to me on this my email ID, and best wishes for all of you for your DIC 1 exam. I hope the other session must be coming for you, and try to read all those important topics that what we have discussed today. I think it will be very, very helpful and useful or effective for you all guys. Any question, if you have, you can write on the chat box, or I think we'll switch to our next class. Thank you.